And today I would like to talk to you about the three most important components of hallux valgus surgery. Hallux valgus is a very common problem, and according to Nick's writing in the Journal of Foot and Ankle Research, it will affect 30% of the population at some point in their lives. It's a very complex deformity in that it doesn't just affect the first metatarsal phalangeal joint, but as the years roll on, it can end up involving the whole forefoot. As you can see here, the hallux drifts laterally, and it just starts to encroach on the lesser toes. That results in digital deformities and footwear irritation. Patients also develop interdigital lesions between the toes due to the overcrowding. In the presence of hallux valgus, the first metatarsal phalangeal joint doesn't function properly anymore, and therefore it can result in overloading of the second and sometimes third metatarsal phalangeal joints, resulting in pathologies here also. According to Coughlin and Mann, 70% of patients will complain of pain around the medial eminence of the joint, and 40% will develop pain and callus formation underneath the second metatarsal head. In my experience, it's quite often these secondary pathologies that actually prompt the patient to seek a surgical opinion. For me, surgical planning starts at the initial consultation, and at this stage, it's really important to establish the problems that the patient is experiencing and also what their expectations are from surgery. If the patient has very unrealistic expectations, then ultimately both the surgeon and the patient will be unhappy with the outcome. I try to get the patient's expectations as realistic as possible, and it's also very important to back this up with clinical evidence. I've been using the Kilmartin digital goniometer for about the last 10 years in practice, and I would find it difficult to assess a hallux valgus deformity without it. Unfortunately, it's not coming out very well on the slide there, but I know Algeos sell them, so I'm sure the Algeos guy can point them out in his magazine for you. But when you measure the hallux valgus angle, you have a quantitative measurement, which actually seems to mean a lot more to the patient than the terms mild, moderate and severe. It also allows us to actually monitor the progression of the deformity much more accurately. And I'm now at the stage where I've been in practice so long that I'm seeing patients back maybe 7 or 8 years after an initial consultation, where at that point it maybe wasn't deemed that they required surgical correction. But I'm always delighted when I see them again, look back at my notes, and I have a record of what the hallux valgus angle was when I initially saw them. And you can then tell them with some confidence exactly how much the deformity has progressed in the intervening years. It's also important at this stage of the consultation to measure the range of motion available at the joint also and keep a record of that. So what are these three components? They're the intermetatarsal angle, the hallux valgus angle, and the sesamoid position. In a normal fit, the intermetatarsal angle measures 7 to 9 degrees. The X-ray here gives us an intermetatarsal angle of 14 degrees. So I know when I take this patient to surgery that I need to move that first metatarsal back into the foot by 7 millimeters, because 1 millimeter is equivalent to 1 degree of correction, and that will restore the intermetatarsal angle. The hallux valgus angle, what we aim to do here is to reduce this down to less than 15 degrees. And we do that by removing a little wedge of bone from the proximal phalanx here. The aim is to have the hallux lying parallel to the second toe. If the hallux is still touching the second toe at the end of surgery, there's a greater risk of recurrence of the deformity. The sesamoid should lie directly underneath the first metatarsal head. You can see in this case the sesamoid is displaced by 7 millimeters, and that's because the first metatarsal starts to splay out of the foot in the presence of hallux valgus. So again, we know that the first metatarsal here must be moved back in 7 millimeters in order to realign the sesamoid. It's also very important to assess the position of the tibial sesamoid at the end of surgery, because if the tibial sesamoid lies medial to the first metatarsal head, the patient is at grave risk of developing hallux varus. I'm not sure if you know what the 11th commandment is, but it is, "Thou shalt not commit varus." So what surgery aims to do is restore the intermetatarsal angle, reduce the hallux valgus angle, and realign the sesamoids to a normal position. I'm now just going to show you a short video as to which will illustrate how I explain surgery to the patient. Just play the video, Connor, please. Any chance? No? Well, what I do is I first of all explain that I will make an incision along here and then just remove the bump. I then cut the bone along in a Z shape and move it back into the foot and fix it in the new position with 2 screws. Then I take a little wedge of bone from the big toe and bring that back straight, and then you can sort of see how the foot will look at the end of surgery. I also explain that it's important that they still have a good range of motion at the end of surgery, as that really is essential for a good long-term outcome. So in conclusion then, it's very, very important to address all of these components, the intermetatarsal angle, the hallux valgus angle, and the sesamoid position during the correction of hallux valgus. If even one of these components is not addressed, the patient is at grave risk of failure of the surgery and recurrence of the deformity. Thank you very much.
Thanks very much, Claire.